work hard. And today we are very pleased to have Adam Bosworth to talk to us about bringing health into 21st century. Adam comes from a very distinguished career. He has built many technologies that brings Google Health, Microsoft Access, Microsoft Internet Explorer to the marketplace. He previously, while he was at Google, he was responsible for the development of Google Calendar, spreadsheets, Google Health. Literally, I guess everything you're using every day all have been touched by Adam. Adam is now interested in bringing health into 21st century by building novel tools that will enable things that was not possible before. And he has founded a company. He's currently president and CEO of Keas. And so please join me. Welcome Adam for the wonderful talk.
Well, thank you for inviting me. And let me start by saying that this is an unabashed recruiting pitch. One thing you learn when you do a startup is there's the idealistic year when you think you're going to change the world by sheer build it and they will come. And then there's the, okay, we actually need people to help us get this done and money. And we're very much in a recruiting mode right now, and I'll talk about what we want to do and why. I spent about 25 years of my life doing what I'll call building Lego blocks for adults. I basically built tools to help people build solutions, whether it was spreadsheets or databases or the XML technology or what have you. And you hit a point in your life, which most of you are too young to hit, but some of you aren't, where you think to yourself, am I doing something useful? And I sort of looked up and thought, no, I'm probably not. And at the same time that happened, I had a bunch of encounters with our healthcare system. And our healthcare system is not in the 21st century. There are certain parts of it that are in the 21st century. The diagnostic tools are certainly advanced, et cetera, the use of radiology. But in every other endeavor except healthcare, we tend to now go online and use mobile access to interact with the system. And more importantly, anything that can be automated or routinized has been moved out of the service industry's hands into the consumer's hands. And both sides are a lot happier. The consumers are happier because you get to do what you want when you want it. For example, I booked my flight that I'm about to dash off to after this talk to D.C. I booked my hotel online. I printed out my boarding pass this morning. These days, the other day I flew back on Continental. I didn't even have to print out the boarding pass. It shows up on your iPhone and you wave it in front of them. You know, we have moved to a model where, by and large, we took anything that could be routinized and we moved it out, except in healthcare. In any other system, you can look at your data and see how you're doing, except in healthcare. In any other system, you can now work online with the professionals in whatever system you need, whether it's buying things or managing your money, except in healthcare. And so I took a hard look at this about 5 years ago and thought we can do better than this. And that's really what I want to talk about today. We have a basic problem in our healthcare system. We spend twice as much per capita, and that's as a percentage of GDP. It's actually more in dollars than anyone else on the planet. We do not have anything resembling twice as good outcomes. We're number 37 on most metrics in the top countries in the world. Part of the reason is that our healthcare system isn't a healthcare system. It's a sick care system. We basically wait for people to get sick, and then we treat them. And even then, we wait for them to get sick enough that they're willing to go through the difficulty of finding a doctor and getting on the doctor's schedule. And sometimes they don't bother or they need to switch. The system is failing. By any objective measure, we are a dramatically less healthy population than we were 20 years ago. And that's a staggering statistic. We are particularly less healthy in terms of the things that are actually costing the real money. Obesity-related diseases. Heart disease, diabetes, back pain, chronic obstructive pulmonary disease. The only thing we've really improved on is smoking. Too often, as I said, the system is a sick care system. We wait for people to get sick. My sister actually has spent 3 months in a very good hospital that I won't name, not getting diagnosed. And finally this week I ran out of patients. And I sent her to my internist, who I know is very good, and said to my internist, look, I'm paying the bills, just look at her, which she did, and now I know she's going to get cured. But she was sitting there in pain for 3 months. It's a very typical experience on the part of people who suffer with the healthcare system today. And it's also driving us broke. Not only is this morally indefensible, it's fiscally indefensible. Our lifestyles, it's not working for us. You know, we as consumers are much heavier. There's a slide I didn't have time to put up today, which is an amazing slide. It's a time-lapse slide showing the percentage of people who are obese in this country, starting in 1986 and rolling forward to 2006. And it looks like one of those alien plague invasion science fiction movies. You see the alien plague land somewhere around Knoxville, Tennessee, and then slowly spread out. And as it goes from yellow to orange, the rest of the nation starts to go yellow. As it goes from orange to darker orange, the rest of the nation starts to go orange. As it goes from dark orange to red, the rest of the nation starts to go red, and so on. And 20 years later, just 20 years after 1986, one state in the nation, Colorado, has less than 30% overweight and obese population, whereas in 1986, no state in the nation had as many as 30%, and most of them were under 10. This is not a cost-free decision. The decision to eat fast food, the decision to get heavy, does not come without consequences. It leads to something called the metabolic syndrome, particularly because of the kind of food we eat, which tends to drive all sorts of interesting, exciting biochemical things to occur in our body that, by and large, not only lead to us getting diabetes and heart disease, but actually increase significantly our risk of cancer. From an epigenetic point of view, they basically trigger a lot of oncogenes. They inflame the walls of our heart. We have lots of cardiologists these days, and our cardiologists these days are not treating the curing the problem. They're treating the symptom. They find a blocked artery, and they stick a stent in it. They don't help you unblock the arteries. And one of the ironies is that the human body is extraordinarily good at helping itself. You would tend to think as a human that there's sort of a fairness model, that if you've spent 15 years eating French fries and hamburgers, it's 15 years of tofu and water before you're back to square one. And the thought is too daunting for most people, and they just sort of give up and put their head in the sand. But this isn't true. In about 6 months of a reasonable diet, you can clear up your arteries to a dramatic degree, to the point where you don't need stents and don't need coronary disease. And the other issue is stents both have consequences. Some people die of them. They're incredibly expensive. And you have to keep repeating them, and still they don't keep you alive. Because at the end of the day, the artery that kills you isn't the one that was blocked. Arterioles form around that one. It's the one where plaque broke off and just suddenly shut it like a valve. So it kills people. If you look at the metabolic syndrome, you can see the increase we have as we get older. But the interesting thing is to look at what happens to coronary heart disease, to myocardial infarctions, e.g. heart attacks, and to strokes, if you have the metabolic syndrome versus if you don't. Those are very dramatic statistics. Even more scary is what's happening to our kids. The percentage of childhood obesity in this country is massively up. And once you develop habits as a kid, it's very hard to change them. It's not only not working for us as consumers, it's not working for the doctors. When I went to Google, I had decided I wanted to go work on health and stop building Lego blocks for adults. And I got sidetracked for about a year and a half building what's called Google Apps. I guess if you were at Microsoft building apps and went to Google, that was inevitable. But finally got to work on Google Health. And the first thing that happened was an unbelievable number of extraordinary resumes showed up on my desk of people who had made it through Stanford's cardiology residency. They'd made it through Johns Hopkins this, all asking for jobs at a fraction of the money they would otherwise make. And I said to them, why would you want to work for me? You studied for 15 years. I can't even imagine being in college for 15 years. You've worked insane hours as a resident. Why would you want to work for me? And what I learned is that the doctors are miserable. Not as much the specialists, but if you talk to the primary care physicians out there, they've turned into assembly line workers. And that is not why they went to medical school. They see 5,000 people a year on average. Imagine that. That's 25 meetings a day. Imagine if you literally were in a 25 meeting a day and this way to try and treat people you knew nothing about when they walked in. And you got dinged if you took more than 12 to 15 minutes because you could no longer do your 25 a day quota. That is not why they went to medical school. They earn about $25 to $30. I got married about it a year ago. My wife made me go to a better barber. My barber charges more than my doctor gets for seeing me. In one case, my hair might look better. In the other case, I might stay alive. We have a real mismatch here. You might think, well, boy, we're spending so much on medicine. Why do they need more? We'll cover that in a moment. They have no tools to help consumers manage their health on an ongoing basis. If you're lucky, you see your doctor for 30 minutes a year. That leaves a lot of minutes when you're not seeing your doctor. And about 30% of Americans actively and urgently need oversight and care. They're either sick or on their way to getting sick. And the doctors have essentially no tools. The closest thing they have now is a really exciting thing called information therapy. Information therapy means they give you a PDF. And you go home, and then they hope you read the PDF and you change your life. This is not what actually occurs. And so the system is not working for them either. This is not a system that was designed in favor of doctors at our expense. This is a system that works equally badly for both parties. They don't get paid that as much as you think. We spend $2.3 trillion a year on health care. We are on track in the next 5 years to be at $3.4 trillion. Even in today's bailout terms, that's real money. Or put differently, the total bailout was about $900 billion, the sort of core bailout. We're going to be spending that every year just on the increase in health care in 5 years. That's just the extra we're going to be spending. It's as though we're going to have an annual bailout. And again, remember, we're not getting much for this. But if you look at the amount of money out of that $2.3 trillion that goes to doctors, it's less than 1%. So primary care physicians. When I first put up the slide, I got all these anguished pieces of email say that can't be true. Where's your data? Well, my data was I went out and asked two very basic questions. How many primary care physicians are there? The people who are actually on the front line, the obstetrician gynecologists, the internists, and the sort of general practitioners. And I consistently got back somewhere between 130 and 150,000. And I said, how much did they gross, not net, gross, after they paid the malpractice insurance and their insurance filing fees? And again, coincidentally, I consistently got back between 130 and 150,000. Well, if you multiply those two numbers, you get about 19.5 billion. Even if you round them up to the top, you don't get over 23 billion, and 23 billion is less than 1%, it's 1% of what we're currently spending on healthcare. Or put differently, if all the money we spend on healthcare, 1%, is actually going to the people who could keep an eye on you and help you to stay healthy. 99% is waiting for you to get sick. It's not just that it's 2.3 trillion. It's going up very quickly. We have this thing called the baby boom. I am a prime example. Baby boom are people born between 46 and 64. There's a lot of them. People who were born in 1946, if you do the math, are right about to be in 65. And as these people age and they live the lifestyles they've been living, they are getting sick in a very different numbers. Most illness actually hits heaviest on the 60s and the 50s. It doesn't hit as badly as you think on the 70s because the people who really live bad lives are dead, somewhere in the early 70s. So you actually see a weird improvement briefly. And then people, end of life, we spend a crazy amount on end of life, a separate issue. So as the baby boomers age, and we are aging, this is going to get a lot worse unless we do something about it. This is why the projections are we're going to go to 3.4 trillion and then up to 4 trillion in the next 10 years. It's not because we're going to double our population. It's because we're going to double our health, the people who need health care. It's also a disaster for the people. These people who get these diseases, they can go blind, they can end up on dialysis. It means constant pain and a life expectancy of 10 to 15 years. They can end up unable to walk and carry their grandchildren. They can end up with no sex life, or all of the above, very easily. Now, this is completely avoidable. That's one of the things that I discovered when I went to Google that just shocked me, was that most of the things we pay most of the health care bills for, and most of the people who get sick and die, are largely speaking things that could be avoided. I used to think that disease was like lightning. You got struck, you had very bad luck, it was like being hit on the golf course, what could you do? But it turns out that's not true at all of what's happening to us. Almost every disease has a healthy component. It's not always what you think. As a good example, again, I have 3 herniated discs, severely herniated. The guy who did the MRI was very excited. He wanted to take it back to all of his students at med school as a textbook example of what a herniated disc looks like. And I went through about 5 years of chronic back pain. Back pain is no fun. And I lived on a period, it would flare up for 2 or 3 months a year. And when it flares up, you either take meds or you are just beyond unhappy. I was trying to run engineering at Google at the time. Staying home and being very unhappy wasn't an option. But if you don't, you end up on Celebrex and diazepam and codeine and stuff, and that's not good either. My doctor was busy telling me I should have back surgery, but by then I had started to work with the medical community on data. And one of the things I discovered is there is no data supporting most back surgery, particularly for lower back pain. In fact, the data suggests don't do it. So I didn't. And then one day, completely by accident, about 3 years ago, for nothing to do with my back, I learned a breathing routine, just a classic meditative, relaxed breathing routine, and I discovered my back stopped hurting. Next time my back started to hurt, I did the same thing, stopped hurting. I haven't taken any meds since, but about 6 months after that, I walked into my doctor's office and I said, "Did you notice I'm not taking meds anymore?" He said, "No." Now, for your information, those meds that I listed are not meds that you can automatically refill. When you go back to get more Celebrex or diazepam or codeine, in theory, your doctor needs to look at it and at least think about why are you taking these meds. So the no all by itself was slightly scary. But the second thing was, he said, "Oh, that's very interesting. How are you doing it?" And I told him, and he said, "Oh, that's great. You must be one of the very few people who can relax your back muscles through brain." I said, "How do you know? You kept telling me to inject steroids into my discs. You never told me to just try breathing and relaxing. You probably have 200 people on your panel of lower back pain. If you didn't tell me, I'm sure you didn't tell anyone else. So how do you know what the percentage is?" We don't know. One of the things that's scary about medicine is we don't know how often, even when the data is curable by behavior, we don't know that it's curable. There is a solution. Well, I don't want to overstate that. Saying there's a solution to the problem might be an overstatement. But there is a way to start to attack this. And really, that's what I'm here to get your help to do. The way that, in general, we have made systems work better and more efficiently, everywhere except health, is we have harnessed the intelligence of the consumers and the intelligence of massively scalable computing delivered anywhere at any time on the net, and now over the phone. And we have, in turn, built applications. We've built applications for travel. We've built applications for finance, for shopping, for picking restaurants, you name it. In most cases these days, we take it for granted. I was talking actually to a doctor yesterday afternoon, all of whose patients come from Yelp. Because he figured out, boy, there's a lot of people looking at Yelp. If I do a really good job on Yelp, people will show up. He started focusing on that. Now his entire business, it's a very good business, he's one of the few doctors making money, is coming from people on Yelp. What most people do, since they can't get into their doctor, and they do suffer, is they go to the internet and they go to Google. I know a little bit about this because that's where I first went to try and solve this. And they search. An astonishing number of them search a day. Tens and tens of millions of health searches occur every day. And they get back a lot of data. The problem is that what they get back is the data that effectively was most popular about the query words they typed in. This works great for a whole bunch of services, which is why we all use Google without thinking about it. But it doesn't actually work very well for getting relevant data about what you need to do that's precise to you. And people end up with sheets this thick of printouts that they bring into their doctor's office. That doctor only had 12 to 15 minutes, if you recall. Most of that printout is not relevant, but now the doctor has to talk about it, and they're extremely pissed off. The people who brought it in are humiliated and upset. They've been trying their best to do the right thing, only to be dressed down by their doctor. It's not a good experience all around, and it's not effective. And the reason is there's information overload. What most people need, in general, is not so much information as guidance. As a different example, let's look at finance. If you go on the net today, there's a thing called Mint.com. How many of you have ever heard of Mint.com? Okay, well, for those of you who haven't, Mint.com is a very handy tool to help you both understand whether you are managing your money well, and B, remind you of the things you need to do. You don't pay for it. It's really useful. And Mint.com sits on top of a product, unbeknownst to most people, called Yodlee. Yodlee was written to assemble all of your financial data. And when Yodlee came out, there was a huge collective yawn. They moved heaven and earth to be able to integrate with your brokers and your bankers and everything else to pull all your data together. And when they finished, what did they have? They had a lot of data. And you go and you look and go, oh, that's interesting. I have all this data. Okay, goodbye. And you'd never come back. Because there was absolutely nothing you really knew what to do with. Mint.com figured out, oh, we could actually help you use this to put together a plan based on your goals, help you understand how to get to that plan, give you useful reminders, and while we're at it, remind you to pay the bills you need to pay when you need to pay them. And they grew so fast that Intuit hastily bought them before there was no more Intuit. And in healthcare, we can do the same thing. We can deliver 1,000 Mint.coms. Why 1,000, not one? Because there are many, many different illnesses. that we have to face. And they all have different prescriptions. There are people with asthma. There are people with pediatric asthma, which isn't the same. There are parents worrying about kids with autistic children. There are people at risk of diabetes, and there are people at risk of renal failure who already have severe diabetes. There are people with gestational diabetes. There are actually a staggering number of various health issues, and it's not a one-size-fits-all prescription. For example, in general, it's fairly effective if you're trying to lose weight to eat fewer carbs, cut down your glycemic index, eat more protein. But if you're diabetic and your kidney is at risk of failing, you have to be very careful about protein. It can accelerate kidney failure, and you end up on dialysis. We can give people the plans they need, but this is where I really need your help, and I'm going to sort of talk about what can we do. These are some examples. I sort of casually put down an alphabetic list, but this list isn't completely casual. We went out and we chatted with a bunch of people who actually pay the bills. The people who actually pay for the $2.3 trillion in health care. Virtually all of these are front of mind for them, or for parents. These are all ones that either cost them a lot of money or hurt productivity. If you talk to consumers, you get a slightly different list, but it's not that different. Some of them are new. Gestational diabetes used to be a very rare disease. It's actually a pretty frequent disease today. Anyone know why? Well, in order to get gestational diabetes, two things need to be true. You need to be young enough to be pregnant, and you need to have diabetes or be a very, very high tendency towards it. That used to be unusual. But the number of people in this country, I was down again back in that Kingsport, Tennessee sort of center of the virus that landed about 2 weeks ago. They have 64% of the people who are overweight or obese in that county. And the number of them who at the age of 30 are already chronically obese is high, but they're still having kids. At which point they tend to get gestational diabetes. So we've seen a massive increase in that, which is very bad. It's worse than just normal diabetes. It puts a huge stress on your kidneys. So, as I said, all of these diseases can be treated, but we effectively need a mint.com for each one. We need to give people the tools to change their lifestyle. They need to be personalized. One thing we discovered very quickly at Keas when we started rolling out Keas, and right now Keas actually has the problem I'm about to describe. We're busy fixing it. Is it's not enough to give people content. It's not enough to give them a PDF, but even if you sort of interact with them, you put up some questionnaires, you find out the specifics about them, and then based on their data and their lab results, you put up the specific content that actually is germane to them, people feel like, oh God, you're pushing content at me. I'm going away. This is not fun. End of discussion. It's not true of everybody, and we have a bunch of loyal users, but it is definitely true enough. The content has to feel personalized. What people are really looking for is something that's about them. What makes mint.com effective is that the mail that you get or the thing that you see on site is about you. And you know it's about you. It's got data about you in it. Your American Express bill isn't paid. Your account at Citicorp that's used to pay your dad's caregiver account has suddenly dropped down to under $1,000. I don't know how mint.com didn't warn me about that one. You name it. It's personal. And one of the things we found, talking to people, is if you want people to engage in managing their health, it does need to be personal. The consumers are extremely ready for this. Now, you guys take this for granted because you're at Berkeley, and I assume everyone here is on the internet generation. But it's worth noting that in the healthcare field, as recently as 3 years ago, when I left Google, virtually every doctor would tell you, oh, consumers don't want to have access to their health data online. Now, in California, we have an interesting thought experiment on how untrue this is. It's called Kaiser. We have 8 million people on Kaiser. Kaiser has a thing called the PHR, which is a terrible name. It's like what Yodlee was for finance. Yodlee was this personal financial record. All your data, nothing useful. PHR is personal health data. And you don't know what personal health record. You don't know why you'd want that. What you want to do is understand your health and what to do about it, and get the tools and reminders to do something. But that being said, Kaiser has a PHR. And even with those limitations, it's massively used. And the feature that is used most is just looking at their lab data or asking for help from the doctor. People are using it, and they're using it in huge numbers. So we went out at Keas to build something that was not the mint.com. It was a way for you working with our partners, with doctors, and with others to build 1,000 mint.coms, or maybe even 10,000 mint.coms, all oriented around health. For example, there's some kids from Berkeley working with us, one of whom suffers from severe Crohn's disease. Now, Crohn's disease is a rare disease. Normally, you wouldn't get a lot of people to work on it, but it turns out they got a grant. And they were going to go off and build sort of a proof of concept that you could build a tool for Crohn's disease users and have 30 people put on it at a cost of $450,000. We said, look, for $30,000, probably less, probably 10, you can put this up on Keas and hit every Crohn's disease user in the world. And then go figure out what's going on. And then figure out how to make your plan better with the other $420,000 or whatever it is. So that was one of our focuses, is how do we make it really, really easy to build sane. Now, any plan needs to start with your data. It needs to have information about it. If you talk to doctors, one of the amazing things is they have no idea what you're doing when you're not in the doctor's office. Sometimes they don't care. You know, if you're a healthy 24-year-old living the right life, you're not even seeing a doctor. And if you were, they'd say, yep, you look good, you're fit, go away. But if you've got someone who's at risk of most of these diseases, it suddenly becomes very interesting. What is their lifestyle? What's happening in terms of their exercise, their diet, their mood, or anything else you want to track? And in the case of these Crohn's disease kids, it turns out what they want to track is stuff we'd never have thought of. And the good news is they can do that. You need to have access to your data because not infrequently your health data is a factor in what decisions you get. And I'm going to give a quick demo of this so you can see why that's true. But you need to have electronic access to your data. At the same time, it's not about the data. It's about what do you do with the data. And that is basically giving people the weekly advice they need, the reminders they need, and the attention that their doctor would give them if their doctor could. And this is at the heart of the 21st century part of my title. In every other business except health, anything that you can get as advice that can be turned into computer algorithms has been turned into computer algorithms and is delivered to you online as advice. When you want to figure out what's the best way to fly, as I did the other day, from Helena, Montana to Kingsport, Tennessee, you go on Kayak. And Kayak does this astonishing thing of giving me all the choices of all the possible ways in which I could get there sorted any way I want. And no way is good, but at least I can figure out the least of a bunch of bad ways. All that was routinized, right? All that has been turned into intelligence. Doctors have not taken any of the routine intelligence that they have and turned it into something that's done online. And that's a huge waste because, as we know, we don't have enough time. The doctors don't have enough time. They don't see you enough. In Massachusetts, where they finally gave everyone what they should have done a long time ago, the right to have medical care, it now can take a year to get a checkup from a doctor. But it's because they don't capture any of the data ahead of time. They don't keep the medical data online. There are a variety of things that are inefficient. Doctors do not, as I said, have tools to help people manage themselves when they're not in the office. And yet most people are not in the office 99.99% of the time, maybe even 99.99% of the time, which is very rare. You hear people say they want 4 nines in business, but they don't know what they're talking about. What they really mean is, the system can only be down 6 minutes a year, and you could never change the system. And mostly we don't do that. But in the case of people seeing doctors, we sometimes see that level of intensity. It is really, really easy now, with what we've built, to deliver these kinds of self-management tools, where a doctor can say, look, you have this problem, let's put you on this. But again, I'm here to recruit because we need your help. So that's a lot of talk. I wanted to just show the product. It's a lot easier. This is Keas. There were some misconceptions in Keas, and I'll talk about them briefly as we move forward. One of them was we thought people would want a Facebook for health. So basically what Keas laid out here is on the right, how am I doing? On the left, everything I need to do or have done, or other people think I should be doing. Think of that as a Facebook for health. Turned out people did not want a Facebook for health, and we're busy on doing that. One example is this community tab. We had all the things that everyone who was on the same care plans as you were saying intermingled with this thing on the left, and people complained bitterly. They wanted to go someplace to see the community, and it wasn't the same place as they saw what they needed to do to manage their health. Might work in Facebook, did not work here. So we're busy. We took that out. We had news flowing in here, same issue. So there are a bunch of issues like that. But succinctly, there are these things called care plans. And care plans tend to give you both a control center. And this one here is Men's Preventative Health, because I made the Berkeley person a sample man. And it's just sort of telling me what it's going to do. It's going to talk to me about sort of what my weight should be, explain to me about cardiovascular health. It's going to explain to me about cancer prevention, and so on and so forth. This is not the greatest care plan in the world. We learned a lot from the first. We launched in October of last year. So in the first 3 months, we learned a lot about how to make these better. And again, that goes back. But everyone who builds a care plan can create a branded experience within Keas. And that experience can include personal data about you. It can include tools for you to do what you need to do, reminders, etc. We're going to see that in a moment. Over here are the indicators, and right now the indicators aren't really set up, and I'm going to sort of show you how we'll do that. But to do that, I'm going to go back to the care plan, and I'm going to take a feature that we think is part of what's going to make this useful. I'm going to go find a mobile care plan, and I'm going to join it. Now, this mobile care plan, I'd normally put in my cell phone, but I'm going to demo this time, so I'm going to say instead, test Adam. And it's going to go through Twitter and onto a little console that I have. These are all various things I could type at any time into mobile once I join Keas. So let me do that right now. Let me go over to here, refresh. It says reply with Keas, which I need to do once when I first get on this plan, and then I'm linked. Make sure I'm linked. And now I'm linked, meaning that normally I'd be talking to my iPhone or my Nokia phone or what have you, but here I'm talking to this little console. But once I'm linked, I can do some cool things. I can basically remotely record what am I eating, what's my exercise pattern, what's my mood, or a bunch of things that Keas just generally understands about your lifestyle. I can get data. For example, I'd set, I believe, let's go back here. I had set my diastolic blood pressure, and I could go and pull that up from my remote phone. So if I'm in my doctor's office and they said, what's your systolic or your diastolic most recently, or what was your readings in this, I could just pull that up from Keas on my mobile phone. But what I'm going to do this time is I'm going to run a demo first. Actually, you know what? I'll take it back. I'll first demo this. So I'm going to set my weight here. Mercifully, this is not my weight, but I'm not good on on PCs. Some of us are hardcore Mac users. So that's what you would normally text in. And if I go back here and refresh the screen, there's my weight. And coupled with my weight is a little sort of color-coded thing that shows me where I am and where I should be. Now, this is a simple example of us helping you understand your data in Keas. Anyone who builds care plans, and as I said, I'm trying to recruit people, think of these as the mint.coms, can take any set of data that might be relevant to you and build a color-coded model like this, and they can personalize it. What's red, what's yellow, what's green, or what's any other color you want can be a function of your profile, your progress, and your goals. So what you see, both in terms of what you keep an eye on and also where you should be, is up to the care plan. And a care plan can personalize it to you and your profile. The content over here can be personalized as well to give you tools to do better if you're not where you want to be. So I'm going to put us on a care plan for the purpose of this demo that I wrote over the weekend for a talk I'm giving tomorrow. Now, this is a little care plan that essentially started by being a PHR. You remember I'm very skeptical about PHRs, but they're still a useful starting point. And it gives me ways to do some things. I can look at my lab data, and I can see what my labs are. And you'll see we did the same thing for diastolic and cholesterol and systolic and everything else. We sort of show the user, how are you doing and where should you be? And for any of these, I can drill in. If I wanted to understand what my cholesterol means, I could click over to here, and there's my cholesterol. But I don't at the moment. So let me close that up. I can look at my medical history. I can look at my medicines. I can update my family history, exercise history, eating history, mood, and so on. I can set up to get some smart reminders to walk or do what other kind of exercise models I might want just to get fitter. So it turns out I walk to work most days, and my goal is to walk to work at least 3 days a week. It's 4 miles. It's not perfect, but it's better than nothing. But I particularly want to get nagged about that if my weight goes over a certain level. But what I wanted to demo here is the kind of thing everyone in this room could build, which is not just this page. And notice the page itself is personalized. This says, Hi, Berkeley, because we said the username here was Berkeley. But I'm going to go over to here, and it's going to say, Welcome to this part of the plan that tracks your daily aspirin. Oh, I went on the wrong thing. Whoops. I wonder if that's going to break the demo. Well, let's find out. This is what happens. My apologies. Okay. So up comes a piece of content. It's not pretty, but I want you to understand what I did here. This piece of content that the care plan put up, this is not Keas. It's personalized to me. It's telling me what my heart attack risk is based on the data that I actually set up in this profile. It's telling me how old I am. And then it's going to say to me, basically, I'm okay. I don't need to be on what's called aspirin therapy. And this was just a little one, do I need to be on aspirin therapy? I went and got this from the doctors on Friday. They said, here are the rules for whether you should be on aspirin therapy or not. And I just sort of coded that right in. The reason I shouldn't be on aspirin therapy is because my risk of a heart attack is less than 10%. It turns out if my risk of a heart attack goes over 9%, given the age I assumed I would be, then all other things being equal, I should be on aspirin therapy. I'm going to go over here, and I'm going to imagine, however, that I was happily using my mobile phone, and I was using my blood pressure cuff, and I got around to taking my blood pressure, and something bad happened. My blood pressure came in very high. Everybody with me? Now, if I go back to Keas, and by the way, I could have typed this into Keas. I could have a form on Keas, but I sort of want to get a sense you're not tethered to the application, because one of the things we know is people don't want to be. And you'll notice my heart attack risk just went up. I'm at 10%. One of the ways that a care plan works is sitting on top of your profile, something you can think of as a spreadsheet. And that spreadsheet can be as complex as you want. And this one is using a bunch of studies called the Framingham studies to look up basically what is your risk of a heart attack given the data that it has. And if it doesn't have that data, it puts up a questionnaire and asks you for that data first and collects it. And then as soon as it's got that data, it can compute your heart attack risk. But in this particular case, I knew, and my heart attack risk has gone up to 10%. And what happens now is interesting. If I go back to the same place I was before, and I go to patient education, it says my heart attack risk now is 10%. You see that? It's a different number because my heart attack risk just went up. And now it does something it didn't do before. It's now thinking, boy, you should be on aspirin therapy, but there are a bunch of reasons why maybe you shouldn't be on aspirin therapy. If you're allergic to aspirin, probably should not be on aspirin therapy. If you have peptic ulcers, at the very least, you should be, actually, to be honest, you should probably talk to your doctor in many of these cases. But again, remember the routine logic. Sooner or later, it's going to need to be moved out. If you have strokes, if you have easy bleeding, these are all reasons where aspirin therapy may not be a good idea. And again, I got this from some doctor who seemed to know what they were talking about. And it says, look, based on what you've just told me, you should be taking aspirin therapy. And then we have this sort of mealy-mouthed, please see your doctor to discuss. But at the end of the day, what it's saying is all things being equal, you should be on aspirin therapy. That's a very simple example of what I'll call a minimint.com, and it says, do you want to start? Now, it's going to put up a daily reminder saying, did you take your aspirin? Most people are not going to come back to the web every day to fill in a daily reminder, which is why I set this thing up to send me a text message. And now if I go over to here and I refresh and everything went well, I get a reminder, did you take your aspirin? And I can say yes. Now that reminder, the text of that reminder, the interpretation of it, all came from the care plan. And the care plan you can think of as something you guys can build. You don't need to be a programmer, you just need to be smart, which I'm assuming everyone in this room or listening to this talk is. You don't actually, it's not like rocket science either. Years ago, I was in India, and they were trying to convince me, this great hospital in Hyderabad, to help stay there and do mobile health for the villages, and it was very tempting. And the person trying to convince me was a guy called Russ Arun. Turns out Russ Arun was one of the two founders of the rocket program. No, Arun Tiwari was one of the two founders of the rocket program in India. And he was talking about how complex health is. And he said, I talk to people and they go, you know, he says, this is really hard. He said, you know, people say it's not rocket science. He said, look, I know rocket science. This is harder than rocket science. And the truth is, when you look at the complexity of healthcare systems, they are incredibly complex, but not for good reasons. Now, you'll notice that I haven't refreshed this yet, so it hasn't sort of caught up with the fact I just told I took aspirin. And it's going to say you've only taken aspirin 0%. And this is like a little guilt meter. It's something that I can keep an eye on, or again can come out to me, telling me what percentage of the time am I taking aspirin. When I refresh, this is going to improve. It's going to improve because I just came in remotely and told that I took aspirin. Now I'm going to do something probably more techy than I should. But how am I doing time-wise before I do this? Okay. 5 minutes? I'm going to go for it. So I'm going to regret this, I know. So I am going to do something a little bit complicated. I am going to pretend it's 2 days later. It's now February 5th, in case you were wondering. And I'm simultaneously going to go to my little SMS gateway and tell it to pretend it's 2 days later. I'm going to go back to Keas and refresh. And my percentage complete just dropped. It's at 33%. One of the ways that a care plan works is it doesn't just recalculate what you should do every time you get new data. It recalculates every day. So if there are things you want as reminders, if there's things that should happen every 2 weeks, if there's things that should happen on certain dates, all of that is built in to the engine. So in this particular case, it's 33%. And now I'm going to do something slightly different again. I'm going to go over to here, and I'm going to send in an unsolicited. And you might think, well, how the heck does it know what took aspirin means? It knows what took aspirin means because when I was first signing up for this care plan, it asked me how I wanted to know that I was taking aspirin and what words I wanted to use. And then the care plan told the SMS gateway, oh, this is what this user wants to tell me when they say I took aspirin. So again, it can be tuned to each user. So I texted in, I took aspirin, and I get back a customized response, basically telling me I need to do a little bit better. Everybody with me? So now I want to pop back out of Keas. We built what you can think of as a spreadsheet for health experts. We built a tool, think of a spreadsheet, not as a spreadsheet, but as a tool to let people who are managing and modeling data and financial data make assumptions about the data and understand data about the data when it's financial. And before that, none of you can remember this, you actually had to use programming languages to do this. There really were no tools to actually do something as simple as a budget, something we now take for granted. What a spreadsheet did was it democratized it. It made it easy for virtually anyone to sit there and put together a budget. We built something equivalent, though not as easy yet, for anyone who's interested and cares about healthcare to put together the kinds of things you just saw. You don't need to be a programmer. You do need to be at least as good as someone who builds an hourly spreadsheet. You do need to know HTML or have someone working with you who knows HTML. And I'll show you why in a second. But imagine that many people like you teamed up with doctors that I'm finding all over the country who actually want to take this intelligence and automate it. They want to deliver what they right now can give to maybe 1,000 patients a year and give it to maybe 10 million people who need it a year, or maybe 1 million people, or 10,000 people who need it a year. Fundamentally, to take the people who have the expertise and join them with the people who need the expertise. We do this in every other industry now on the web. We find the people who need something, and we join it with the people who have it. Think of eBay. We haven't done this in healthcare. We haven't taken the people who have the expertise, for example, about how to deal with Crohn's disease or how to deal with gestational diabetes, and join them to the people who need that. We built a tool to make it possible to do that. Now, if you imagine that we did this, I did an interesting thought experiment. I said, suppose we took a look at how badly our healthcare system works, and we took 1% of what we spend on healthcare a year. We go on spending 99% waiting for people to get sick. We took 1% a year, and we said, look, we will pay you if you make material improvement in your health data. We're not going to pay you just for words. We'll pay you because you actually have lowered your weight, dropped your blood pressure, improved your cholesterol, cut your smoking. Take your pick. Some material improvement in something we know causes you to get sick. And I said, be incredibly optimistic and assume of the 100 million people in this country, at any moment, 40 million people were actively improving, because we're only paying for improvement, actively improving their health data. Everybody with me? It turns out that we have hard data on this. If you pay people about $300 to $400 to $500, you get huge uptake in people trying to do this. $300 to $400 to $500 is real money to a lot of people in this country, and they're particularly the people we're often trying to reach. It turns out that if you gave it to the doctors as well, 100 of it, it would have a huge effect. Why? Because do you remember those doctors are getting $30 a visit? And the thing they want is fewer visits and better quality of care. Imagine that they could actually get $100 to actually improve a patient. They double to triple the revenue they get on that patient. Suddenly they have an incentive to do the right thing. It turns out if you do the math, you could do this for all 40 million who were successful, again, for 1% of the budget. We spend so much money on healthcare that if we paid out $500 to $600 a year to roughly 40% of the people who need it every year for actual improvement, it would only cost 1% of our healthcare budget. That's how much we waste. But it's not going to work unless there's some tools for these folks. And what I need is I need some volunteers. Well, they'll get paid, but I need some people who want to step up and make a difference. They want to actually go out and work with the people who are available with expertise all over the country in actually working with them to build these Keas care plans. We do not own the Keas care plans. The people who build them do. One of the lessons of the web is don't try to own intellectual property. Anyone who tries to own intellectual property soon owns an asset that's stale. Try to let the web be the intellectual property. Look at Wikipedia as the extreme example. How many people in this room even remember, well, mostly you're a little bit older, but how many people remember Encyclopedia Britannica? Okay. There's a large number of hands that literally actually aren't going up.
1793.
Now, to my generation, Encyclopedia Britannica, it was unimaginable it would vanish. And yet overnight, Wikipedia became a vastly better resource, vastly more up-to-date, and vastly more comprehensive. Why? Because they could only hire so many people with so much intellectual expertise at Encyclopedia Britannica. On the web, they could harness the intelligence of everyone in the world. And that's the model that has worked on the web. That's the model we're looking for here. Harness the intelligence of everyone who's got expertise on what works and let them deliver it to the people who need it. One other thought point. I used to work in something, when I was at Google, I was invited, mostly for bad reasons, to sit on something called the Evidence-Based Working Group of the Institute of Medicine. I know some stat, and I'm a computer geek, and they thought I could, and I was at Google, and they thought I could help actually gather data on what works. As it turns out, the really shocking statistic is that, roughly speaking, only 20% of medicine, best case, has data behind it that suggests it's the right practice. 80% of the time is an art, not a science. And mostly we don't know, and people aren't doing good studies. In every other field, we measure obsessively these days because that's how we measure productivity. In every other field, this goes back to the 21st century again, we measure usually week by week what's working. At Keas, when we notice that the users are abandoning something, we go, boy, that's not working. And if 3 weeks go by and we haven't done anything better, we feel bad about it. Not 7 years, which is the average time for a clinical study. One of the things we can do when we build these care plans and we roll them out to everyone in the world, there will be different ones. Let's take gestational diabetes. There may be 10 or 15 care plans built for people in gestational diabetes. We can then measure which of these are actually working for whom. And it won't be a one-size-fits-all. A lot of it will be communication style, how good the mobile design is, how practical it is, how well it learns from how well you're doing. Some will be good for obsessive people who would log every meal they ate, and some will be very bad for obsessive people, and vice versa. But we'll start to gather data on what actually works. And that's what I mean by bringing health in the 21st century. So what we've done is we've built a tool, and we're building about 15 care plans with partners right now. And even there, we can use help from smart folks here because they're yelling at us, we need some help building these things using your tool. We understand medicine. We understand content. We don't know yet how to use your tool. But fundamentally, we've tried to build a tool where the whole world could build mint.coms for health. And that's what I was here to ask for help on. Thank you.
So, do you have any questions for Adam?
I was asked, by the way, if I could stick around after the talk, and the answer is I can, within reason. I have a plane to catch, but I can sit down and chat to anyone who needs to chat until about 1:45.
Hi. What do you do with my healthcare data besides use it for my benefit, and how do you make your money?
Those were two questions. The second one I got, how do I make money? What was the first question?
What do you do with my healthcare data besides use it for my benefit?
Okay, those are very good questions. The answer to the first question is we are looking to take the aggregate data, not the individual data, but what's working for whom, and make money from that. It's one of the ways we get paid. We don't take individual data and give it to anyone. With one interesting exception, we're working with UCSF on some clinical trial care plans. But there you opt into the IFBR. You've specifically said, and even then it's anonymized data, but they specifically wanted individual data to do their analysis, but you opt in anytime we do that. For aggregate data, we are looking at that as something that we take advantage of, and it is one of the ways we make money. The other way we make money is very simple. We're finding people to sponsor the care plans. We're going out to the people who actually pay that $2.3 trillion. And we're saying, you're paying a lot of money for a lot of sick people. Imagine you could lower the incidence. Wouldn't it be worth it to you? they're saying, you bet. At that point, we do a really interesting thing. We're doing a revenue share model where the majority of the money goes to the care plan author, but some goes to us because we're the runtime and the platform and the authoring environment. So we're making money on the percentage that we keep, plus the subscription rate, and the rest goes to the care plan authors. So we've created a financial model where anytime anyone builds a Keas care plan, they stand to gain, and the more effective, the more they stand to gain. Secondarily, we're going to the hospitals. Now, you would think hospitals would love this, right? Finally, you could go home and have continuous care. You no longer would only be able to treat the person when they walked in the door. And they do. I have not walked into a single doctor group or hospital who hasn't sort of sat there and started dancing some ecstatic jig until you say, how much will you pay me? And the reason is very simple. Our doctors are not paid to keep you well. Our hospitals are actually paid not to keep you well. Let me repeat that second sentence. Our hospitals are actually paid not to, with the exception of Kaiser, not to keep you well. Because if you're not well, you come back. Another $30,000 operation occurs. And you come back, another $30,000 operation occurs. If you go home and you learn to exercise, get on the treadmill, and eat less meat and more veggies, you don't come back. The hospitals that have actually tried to do a good job on preventive medicine have not infrequently shut it down. This may change, but there is nothing in the Obama health care bill that actually would cause this to change right now. Nothing. So while we are working with hospitals, by and large, the doctors and hospital groups we're working with are ones that pay the insurance bill. They're like little Kaisers, because they're the only ones who actually stand to gain. And then lastly, we are working with pharma. They're interested in patient education, and they pay the bills. Next question.
What about using the wiki concept for presenting something that is easier for the general public to evaluate their medical positions and handle their questions?
Well, I'm not sure that the two are in contradiction with each other. When you say the wiki concept, you mean what about creating a wiki for people to talk about their doctors?
Evaluating their data.
Okay, so we have a classic community right now. And the community says that anyone who's on a care plan can talk to each other about anything they want. They can establish any topic and talk to each other about that. It's a pretty classic topic and response model. We surveyed the users about whether they wanted a wiki, and we didn't get a lot of uptake. But it would be trivial for us to add a wiki to that. And the moment we hear a user tell us that they want a shared wiki as part of a care plan, we'll give them a shared wiki, or even a set. It's not, as you know, wikis are a dime a dozen. And, we're happy to do it. We just did, right now, what we tend to do is build things people ask us for. And they didn't ask for the wiki. But, I think it's a reasonable question. Yes?
Is this the last one? Okay. Well, thanks for the talk. It's great. I guess the question I'm having here is, as a user of Mint.com, I want to know that not that many people actually use it. I think it's somewhere around 2 million people. And two, it's really useful because it's already populated with my data. I also know that healthcare data is very complicated. And if I'm already sort of able to input my data by text message into your system, why can't I just keep it in a journal? And then, therefore, I guess the question comes down to sort of, are you going to be able to extract the data? Are you working to?
So there really are two questions there. One, how are you going to get the data in a way which is not a pain in the butt? And two, why wouldn't I just put it in a spreadsheet if I could do it? The answer to the first one, in part, is a partnership that we formed with Quest Diagnostics. Most people who get their labs taken in a non-hospital setting get them taken through Quest Diagnostics. Quest Diagnostics provides every single user the opportunity to have their data transferred into Keas electronically. Quest will do the transfer to us. You have to request the transfer, but they will do it. And at that point, none of the data has to be typed in. We don't have such a deal with LabCorp. Between them, you now have 95% of the non-hospital labs, but LabCorp is a deal with another service that goes to Microsoft Health Vault. And in fact, my own data sitting inside of Keas came from LabCorp. I went to a service called My Med Manager. They sent me to a local lab. I had my blood taken. 2 days later, I got a thing saying your data's in Health Vault. Keas was linked to my Health Vault account. I went and pulled up my lab data, and boom, there were all my labs. So part of the answer is we're building electronic connections to everything we can find. We're building to Google, which also can now track medicines, and to Microsoft Health Vault. Both of those are linked today. Most big pharmacies will put your prescriptions into Google Health or Microsoft Health Vault or both. So your meds can flow. As I said, the labs can flow either from LabCorp or Quest. That covers about 90%. Now, meds and labs are most of what you actually need to reason about, interestingly. It starts to drop precipitously after that. If you go out and ask doctors what they want to know, But we're also tying up to a bunch of devices. Like there are a bunch of devices now you can put on your finger that will measure things like stress or how many calories you're burning or whatever, and we're building a model for that. And we're piggybacking Microsoft's model for that as well. So that's part of the answer, is that we're starting to capture more and more data electronically, so you don't have to type it in. And the one we think is particularly onerous to type in is your lab data. The typing in your weight is not such a big deal, though, again, we're tying up to electronic scales. The second part of the question is, what do we do with the data? Why wouldn't you just journal it? Well, we are building a model where you can journal. It journals for you automatically, so you don't have to go and put it in a spreadsheet. But, hey, you might want to put it in a spreadsheet. The big difference is we're doing two things with the data you're not getting. We're showing you what it means for you, and we're telling you what you need to do, if it's bad, to improve your health. Mint.com does a very similar thing. You know, if I'm spending too much on my restaurant bills, they don't just tell me. I could journal my bills just as easily as Mint.com. But what I wouldn't do is I wouldn't be keeping an eye on how much have I actually spent on restaurant bills this month compared to what my budget called for. Now, I actually don't budget my restaurant bills, but you get the idea. In terms of the 2 million, that's true, but you should look at the trajectory. It's not a flat model. It's not like they were started at 2 million and they still have 2 million. They're growing like that. That's why they were bought. And it doesn't mean everyone will use Mint.com. I'm not saying that this is a problem that will solve every problem for everybody. But we are paying $2.3 trillion for health care. We have 100 million Americans in urgent need of oversight and care and tools to manage themselves. I'd be very happy if we at least got 20% of them. I mean, that would still be 20 million healthier people and a savings of hundreds of billions of dollars to us all. So, you know, one of the things I learned a long time ago, and I guess this shows experience, is never let the perfect be the enemy of the good. And, you know, there are things we could do that would be better, but we are learning by doing. And so the short answer is, we're not saying you can't journal. In fact, we encourage people to journal as well. We're saying we're automatically building journaling tools in, but the journaling tools have the advantage they can interpret the data for you and reason from it, which a spreadsheet can't, unless you go and build all the same medical knowledge in yourself. Is that a fair answer?
Good. Thanks very much for
I think
a
he
great
had a follow-up.
talk.
Okay.
You can-